My name is Jolan Walter. I'm the Division Chief of Pediatric Allergy and Immunology at University of South Florida here in the Tampa Bay area. And I'm also honored to be the Robert A. Good Endowed Chair, who has been the father of immunology for our country. I am very excited to be here to share some of my thoughts on WHIM and how genetic testing have moved and forwarded the knowledge of this disease. We are fortunate that for the past 5 to 8 years, genetic testing became a new norm in our practice to the point that many of our patients can receive panel sequencing and easy access to genetics on a routine basis in their visits. And that helped us to offer this testing to a much wider broad of patients that may not have a very severe disease, but notable enough for the clinicians to start to investigate the underlying cause. For WHIM syndrome in particular, the interpretation of the genetic data is of high importance. First, we want to make sure that we have a report that is clearly stating if the variant is pathogenic or a variant of uncertain significance. If we find a pathogenic or likely pathogenic variant, that will be giving us reassurance that the patient likely has WHIM syndrome, and we can actually move forward and consider targeted therapies and additional evaluations. If the patient had a variant of uncertain significance, we will have to do some diligence in reading the report regarding certain parameters of the variant and determine whether we want to pursue a validation of this variant. And validation steps currently are not clinically available, so you would have to talk to a center of excellence and research groups to figure out if your patient's variant is meaningful. The report would be very specific in stating whether the variant is pathogenic by spelling out the word pathogenic in the report. That is a relatively easy process, and then you can be sure that you are facing a patient with WHIM syndrome related to the CXCR4 pathogenic variant. But there would be cases when a variant would be coming back as a variant of uncertain significance, and then you need your knowledge of reading the variant description to decide whether the variant is leaning towards more benign or pathogenic. And that process takes steps of understanding how the variant changed the physical chemical characteristics of the protein. Is there an area which is in a hotspot region? So you actually would have other mutations accumulating them causing disease. Is it present among healthy people in population databases or only in clinically significant cases such as documented in ClinVar? Are there publications of this variant? And lastly, what is happening on the in silico prediction program? So with all that information together, the clinician has to make a call whether he is concerned about this VUS actually leaning towards pathogenic and then potentially doing additional investigations of the patient. Unfortunately, the resources currently are somewhat limited to test the variant itself. So currently, we have to go and start looking for additional signs of the syndrome itself. That would be starting with looking at a bone marrow biopsy potentially and looking for signs of myelokathexis, which is basically the overaging or senescence of immune cells in the bone marrow. You can also look for additional features of the disease clinically, such as warts, history of recurrent infections, neutropenia. And lastly, eventually, you would like to, of course, understand, is this variant behind that? And for that, the best resource is centers of excellence, where additional functional studies could be done on the research side. If a variant is of uncertain significance, I recommend that the clinician don't stop, but reach back to the company or reach back to the nearby specialists who are sort of key experts of the field of WHIM syndrome and have a discussion with them about recommendations on next steps. We are fortunate to be in a world now where multiple specialists engage in the clinical arena, but also on meeting level. I would like to give a shout out to a couple of these very important societies who have been involved with finding WHIM syndrome. One of them is the Jeffrey Model Foundation. Through the help of the Jeffrey Model Foundation, we actually have been developing screening programs for WHIM syndrome, and they have created warning signs for WHIM syndrome. We also think that some of the other agencies, such as Clinical Immunology Society, the NICER, which is a North American Immunohematology Consortium, are all very, very interested in spreading the word between specialists on how to diagnose WHIM syndrome and bringing it to patient advocacy groups. And I'm fortunate to be one of the speakers at the Immunodeficiency Foundation, Lunch and Learn meetings, and also other global parent organizations such as IPOPI. So we had a lot of different parent advocacy groups and societies standing behind the cause of disseminating information knowledge about WHIM syndrome. I believe that the current barrier of information reaching healthcare providers is the fact that WHIM syndrome is not a well-known entity, and people believe that this is such a rare disorder that they will not encounter these patients. And the patients sometimes present with vague symptoms that bring them to the dermatologist, hematologist, immunologist, like different specialists. So the channel of referral is not straightforward for evaluation of these patients. And that is the reason why providers may not think it should be on the high radar for them to think about the disease. The reason why I'm encouraging providers and patients to think about this disease is the fact that we have targeted therapy, FDA approved for this medication. So if we find the right patient, we can actually change their life significantly. And that is the goal, is to bring not just the diagnosis, but a potential therapy for these patients. My message is that with the era of genetics, we should no longer think of patients as a constellation of clinical features, but we should really think of patients of a potential monogenic cause of disease. And WHIM syndrome is a very good example of that. We have been very instrumental in understanding the pediatric side of this disorder, which actually don't display warts until the children get into school age and being around others. So the initial presentation of this syndrome can be as simple as an intermittent neutropenia. There are also some children who will only have recurrent infections. And therefore, I believe that going by the acronym WHIM and people believing that this is how they would find these patients is probably not the most efficient way of searching for this disease. I would like all of the clinicians to have a high alert of finding a CXCR4 variant and considering the syndrome even in an atypical case. I would like to highlight for our colleagues in hematology that the bone marrow biopsy for myelokathexis is actually a very complicated matter. We are fortunate to have close collaboration with pathologists at Harvard, and Dr. Jack Bledsoe just published a paper when he is describing the bone marrow findings of these patients, and he highlights the fact that the bone marrow sometimes can be very under-evaluated or not as much reflective of WHIM syndrome as we would expect in classical cases. So myelokathexis, which was sort of the main column of the diagnosis of WHIM syndrome, is no longer appearing to be a gold standard approach. And therefore, I really encourage our colleagues in hematology to pursue genetic testing for patients with neutropenia, because what we know is that neutropenia is probably the first possible sign of this disease that can happen as early as birth or shortly after birth. So I encourage hematologists and patients with neutropenia to pursue genetic testing. And I also encourage public health officials to consider bringing this syndrome to the newborn screening arena through understanding if patients have low tracks, considering genetic testing for these patients, because once we find a patient early in life, the trajectory really changes. And we showed in our international cohort that those patients who are found with family history or early diagnosis have less end organ damage, including bronchiectasis in childhood. So we have to find these patients in time. we have to work together to treat them properly, and that requires a village.